Lovely to be here. Thanks very much for coming. I'd like to tell you a story today, or actually a couple stories. And we're going to start with this mother. She's from Uganda, and she's living with HIV. We're going to talk about a senior citizen in Cape Town, a soldier in a post-9/11 conflict, and another kind of patriot, a New England patriot. And these four come together because what I want to really talk about today is a peer-to-peer perspective. Our story starts in South Africa. Imagine a mother coming to a clinic, finding out she's HIV positive. At the same time, she finds out she's pregnant. And all she knows is that she's going to die, that her baby's going to die, and that there's no one she can tell. Because HIV is such a stigmatizing condition, there's no one she can reveal it to. So she goes home and waits. This is a global map of the HIV epidemic, and you can see that a disproportionate share of the epidemic is in Africa. There are 37 million people living with HIV, and of these, 25 million are living in sub-Saharan Africa. There are 1.5 million women who become pregnant with HIV every year, and of these, 90% are living in sub-Saharan Africa. We've made enormous strides in the last decades in terms of preventing mothers from infecting their children. The strides, in fact, are so profound that in this country, there are less than 100 babies born every year with HIV. And yet, globally, 220,000 babies are born HIV positive with the most recent data we have. And this is just, it's unacceptable. But why? Why do we experience this? Well, again, here's a map of where HIV is, and here's a map of where the doctors and nurses are. And what we find is that 25% of the global disease burden is being served by 3% of the world's healthcare workers. So we need a different solution. We need to address this in a different way. Because medicines doesn't equal medical care. The access to tests, the access to inexpensive medicines, and now treatment in Africa costs less than $100 a year, does not mean that medical services are being provided. And so Mothers to Mothers was born to address this problem. Mothers to Mothers takes this woman who has come to a clinic and received both wonderful news that she's pregnant and terrible news that she's living with HIV, and introduces her to this woman. This is one of our mentor mothers who says, I'm also HIV positive. Come into this room. I can educate you. I can support you. We can tell you that you're going to be okay and your baby's going to be okay. Mothers to Mothers promotes the well-being and wellness of mothers by embracing a community's single greatest resource, its mothers. We employ mothers living with HIV as what we call mentor mothers, and they are care providers in the health facilities and communities. They provide the education and support to new mothers who are HIV positive and pregnant women. And they work in the facilities, and then they go into the communities to provide care. And they do this every single day. And these are just lay people who've been engaged, they've been trained, and they're paid. And they work side by side with the doctors and nurses who provided care to them when they were patients. The organization's got 3 goals. The first, to prevent mother-to-child transmission, PMTCT, to make sure those babies are born negative. The second, to keep mothers healthy so they can live and support their families. And third, to find ways to empower women, to change communities' perceptions of women and perceptions of what it means to be HIV positive. We have 3 levels of impact. Of course, we take care of mothers and babies one at a time, but we also change community perceptions. We get into the community and change attitudes. And then we're trying to build more robust healthcare systems. As Adam said, we started this program in 2001, 15 years ago. These are the countries in which we've worked. At our peak, we were reaching 20% of the HIV positive pregnant women in the world with the services we're providing. And for this, we've been embraced by the United Nations Global Plan, which is moving to try and eliminate pediatric HIV by the end of this year. And we're very proud to be part of the architecture of these services. But I'd like to tell the story in another way. If we can roll the video, please. Thank you. And so from that, I'd like to pivot to another problem. The world is aging. The United States is confronting an aging demographic. By the year 2050, more than 30% of our population is going to be over 65 years old. What that means, 82% of people over 65 have at least one chronic condition and 50% have at least two. When we look at what we call a dependency ratio, it's how many people are working to provide for those who aren't. In 1950, the ratio was 16 to 1. By 2033, it's going to be 2 to 1. And so those of us who are still working are going to be supporting an enormous population of people who need benefits that we'll be providing. Older adults face extraordinary problems. 28% of older adults live alone and 43% are lonely. And loneliness drives functional decline, which drives poor health and increased medical events and medical costs. So that we understand that the issues associated with loneliness are social, but they're also immunologic. People who are lonely don't do well. We also know that people, as they age and live alone, develop health problems which aren't caught early. To share a story of my father 3 years ago, I got a phone call one night that he was in the intensive care unit with urosepsis, an infection in his blood. And when he came out of the hospital, and fortunately did well, I asked what happened. And my parents said that over the course of 2 or 3 weeks, he had become less active. And this is a man who bicycles and plays golf and tennis, but he became less active and then wasn't getting dressed anymore and wasn't eating and then ended up in the hospital. And the story was that he decompensated over 3 weeks, and he's a doctor, and my mother's a social worker. And I said, how did you miss this? And it's clear that people aren't aware sometimes that those health problems are evolving, and that if we could intervene early, if he had had a blood test 2 or 3 weeks earlier, he could have been managed as an outpatient, but he wasn't. So we need to find ways to intervene. So we've started a program called AgeWell, and AgeWell is dedicated to improving the lives of older adults. We hire able older adults who we call AgeWells. They're trained and employed to visit less able older adults in their homes, to provide care with social content, which is companionship and reducing isolation and loneliness, and health content, to try and identify those evolving health problems. And because they're not care providers, we've built a resource for them, and it's called the 2020. It's 20 questions and 20 observations that, when entered into a smartphone, start to highlight problems. So here, an AgeWell does the 2020 and identifies Alex and asks, are you falling down? Are you confused? Are you out of medicines? And Alex responds that, yes, he is falling down, and yes, he is out of medicines. And using a system of algorithms, it generates a response, which means Alex needs to be referred to see his doctor, and he needs to get more medicines. And a layperson, an AgeWell, can do this on a smartphone because it doesn't require any serious diagnostics. We have a community-based program which works in neighborhoods to find people who live in that neighborhood, to care for others in that neighborhood, and also for people who are coming home from the hospital with conditions like congestive heart failure and lung disease and the complications of diabetes, because we know that those people, 20, 30, 40% of them will be back in the hospital, some within 30 days, but almost all of them within a year. We did a study in Cape Town in 2014 in 2 communities there. We enrolled 270 patients, trained 34 AgeWells. And what we found was a remarkable success in that within a month, the well-being, when we used a WHO-validated tool, the well-being of these clients at home had improved by 50%. And over the course of the study, poor well-being went down by 90%, depression went down by 95%, and we were able to refer people to see their doctors for care. And this is the team from AgeWell. AgeWell is now a WHO best practice, and we're looking to expand it across Asia. And in the last year, I've been traveling the country looking to find partners in America to launch this program. Now, I'm going to pivot another time, once more. In World War I and World War II, for every soldier killed, 1.7 soldiers were wounded. In the post-9/11 conflicts, for every soldier killed, 7 soldiers have been wounded. There have been 3.5 million combatants in the post-9/11 conflicts. 6,800 have died. 52,000 have been wounded, and a shocking 320,000 have traumatic brain injuries, and 400,000 have post-traumatic stress disorders. We're going to hear more about this later from our next speaker. There's a program called the Wounded Warriors, which is looking to engage these soldiers, the warriors who've come home. And they've established 4 pillars: economic empowerment towards finding warriors with job skills and finding them jobs, improving physical health, improving mental health, and trying to re-engage warriors, soldiers back in their communities. And our program, VetWell, is going to partner with the Wounded Warriors Project. We've developed a needs assessment tool which will identify the needs of each warrior. And then another tool which will do the mapping in communities to identify all the services that are there for the warriors. And then we've created linkages so that we can identify through, again, a simple cell phone, through matrices, the linkages that these warriors need to get the best possible care, which will drive the better outcomes, better health, better mental health, re-engagement in their communities, and better job skills. And we're going to be moving to Houston next year in 2016 to work there. And we're creating platoons of warriors who are led by a platoon leader. And so in much the same way we did with Mothers to Mothers and in AgeWell, creating these groups that can support warriors to make sure they get the services they need, to make sure the quality of their lives improve. And for my final pivot, we're going to go to the NFL, where there are 1,800 current players and 18,000 former players. The NFL is the most lucrative of the professional sports, and yet the NFL players are the lowest paid. They have an average career span of 3 to 4 years, and when they come out, they frequently don't have job skills. They frequently don't have any of the money saved from when they played football. They have physical injuries, and they're very much isolated in their communities. And we need to build a program, or we think we can build a program that the working title right now is called Players to Players, where we'll support players coming back into their communities with former players who can provide peer-to-peer support. So to conclude, if you have a good hammer, everything starts to look a lot like a nail. And we think that peer-to-peer support's a pretty good hammer. So we've created an umbrella, which we're calling Peerwell. And Peerwell will provide service to HIV-positive mothers, to older adults, to veterans, and to football players. Thank you.